Hello, and welcome to Among the Lilies. This is a show for ladies who are tired of pretending and are ready to be real. I'm your host, Cameron Brad, and on today's episode, I have Dr. Teresa Hilgers, who is been on the show before, but this is the first time we're doing video too. So I know all of my normal listeners, y'all know her and love her because we had her on, oh gosh, it was pre-pandemic, so maybe, I don't know, a couple years ago, and it's so good to have you back. Oh wait, what's going on? Oh, I hear a feedback loop. Are you hearing that too?
A little bit. There's a little bit. I'm not
Oh,
sure what it is though.
all right. Sorry. Hold on one second. I think, oh, here we go. I just stopped it. Sorry about the feedback. Dr. Teresa,
No
welcome back.
problem.
How are you?
It's great to be here. Thank you for so much for having me on. And it's hard to believe it's been that long since we last talked. That was before the pandemic.
It was. Yeah. I feel like we used to do things in years, but now I feel like we
Yeah,
do it post and pre pandemic.
exactly. Exactly. The last 2 years don't, it's totally distorted my concept of time for sure.
Yes, me too. Me too. Well, thank you so much. I know that you are a very busy doctor, and I appreciate you cutting out this time that we can have you on the show. So, a lot of my women just loved having you last time, and I know, obviously, the primary people you're working with are women,
Yes,
and they
yes.
you just have such a heart for us, and thank you. And then just your passion and zeal to help us. Thank you very
Yeah.
much.
Well, thank you so much for having me here. It's great, and I'm looking forward to our time together.
Yeah, I put your bio in the description below, but why don't you go ahead and introduce yourself a little more to our listeners that aren't
Sure.
familiar with you?
Sure. So, like you said, my name is Dr. Teresa Hilgers. I am a obstetrician and gynecologist. So, I practice medicine mostly geared for women. I help deliver babies, and I deal a lot with women's health care. But specifically, I'm a little different than a traditional obstetrician gynecologist in that I specialize in a form of healthcare called NAPRO technology, which stands for Natural Procreative Technology. And what we do is we really try to get to the root of many of these problems. And when we treat medical conditions such as abnormal bleeding, premenstrual syndrome, recurrent miscarriage, infertility, we try to do it in a way that actually coordinates and cooperates with the cycle instead of using more suppressive techniques. And our goal really is just to figure out what is going on and to correct the problems so that women can feel better and get the best results that we can with the knowledge that we have right now.
Yeah, that's amazing. I often explain to people what you do and who you are as like a true doctor that wants to see, that looks at the whole of the person and wants to truly heal, as opposed to really good at putting on band-aids over certain wounds.
Right, right. No, I think that's true. And, not to like pat ourselves on the back, but I think in NAPRO technology, we really want to look at the whole person. And when it comes like infertility and miscarriages, it's not just the woman who's involved, it's the man. And so the marriage and them as a couple is very important to us. Oftentimes you forget about the male or the husband, and they're just as important part of the marriage as the woman is. And you can't have a baby without them. So it's just so wonderful to see these women or couples, and for the whole person, the total person. I think that's really important. We try not to lose that.
Yeah, and we are on YouTube. So what you just said is really controversial. You're saying
Yes,
it takes a man and a woman to make a baby.
yeah, that's exactly right. Well, actually, we say there's three things you require: a sperm, an egg, and good mucus. And so,
Amen.
in order to become pregnant, we always say you have to have at least those three things. But yeah, you need a sperm and an egg to become pregnant. So you need a man and a woman. And it may sound controversial, but it's really just traditional science and biology. And, but it's really gratifying. I love the work I am in. And particularly, I love working with married couples. I love the husband wife dynamic. And it's just, and the joy that they can have with each other. So it's really gratifying. And I love what I do. So hopefully, we get to share a little bit about that and, and go from there.
No, I totally agree. I I really think if it wasn't for you and what you do and your dad and Dr. Phil Boyle in Ireland, I would not have any children. And
Yeah.
I am so grateful. And I'm always saying that to people. I'm like, my kids are just proof of your work, of NAPRO
Yeah.
technology. And I am
Yeah.
so thankful and so blessed that I accidentally stumbled upon it. You know, I
Hmm. Hmm.
dated someone whose mom was a NAPRO instructor. And so he
Oh
was the
my
one that
goodness.
diagnosed me with endometriosis, which I was like, how dare you? And he's like, Cameron, do you
Yeah.
not realize you're always sick when you're ovulating and when you're on your period?
Yeah.
And this
Yeah.
was a chaste relationship. And so I was offended that he even knew when I was ovulating because I had no idea. I wasn't taught
Yeah.
that. And I'm like, obviously he
Yeah.
knows when I'm on my period because I was that, stage 4 endometriosis,
Yes.
don't function
Yes.
person. And so that was
Yes.
very obvious for everyone. My priest who I worked for knew. He's like, all right, Ann Cameron's out for this week. That sounds right. I
Yep.
have it on the calendar,
Yep.
like he
Yep.
was one of the few priests that actually required an intro session for all engaged couples at the parish. So
Yeah.
before getting married in his church, you had to just go to an intro session of natural family planning.
Yeah. No, I think that's fantastic. And you're totally right. It's amazing what women don't know about their bodies. And that's one thing I love about what we do is it's much of what we do is education. I've had women tell me time and time again, I had no idea my body did this, and I'm in my 30s, or who knew this is what I was supposed to do. Or I've had women in my office telling me about their pain with their periods, and I have to tell them that's not normal, and they look at me like I'm crazy. And what they'll say is, well, I'm not as bad as my cousin who is, throwing up with my periods. But you don't have to be throwing up with your periods to have significant pain. And, women have just such a lack of understanding of what is normal with our bodies, what should be happening versus what shouldn't be happening. And I think that's just kind of a tragedy a little bit in our education system, our healthcare system. I always think like, I often think that, doctor in Latin actually means teacher. And so
Mm,
we should be teaching, our patients
yes.
to the best of our ability. Now, sometimes it's harder to teach certain things than others, and I understand that. And everybody learns a little differently, but at the basis of this is if you teach about the disease process, what normal is, you're going to have a better informed patient who's going to help to take care of themselves, and you're going to have a better healthcare partnership. And whether that's infertility or miscarriage or diabetes or high blood pressure or whatever it might be, that education is so important. And I think that's kind of where we have failed women in many
Yes.
ways.
Agreed.
And it's just a shame. And so that's part of our work. We do a lot of educating.
Let's start there. Okay, take us back to the very beginning. You have
Yeah.
a girl who is just about to start her period. She hasn't even yet. So what age
Hmm.
are we looking at and what is normal and what ought they be being taught?
Sure. So, puberty starts with that, or menarche is what we use as a term for the very first period that a young girl will have. So, you think that could happen 11, 12 years of age, could be a little bit before that, could be a little bit later. And that's where the axis between the brain and the ovaries is starting to wake up, and the reproductive cycle or the menstrual cycle is really starting to um, begin. And the first year and a half, it's not uncommon for it to be very irregular, maybe very short cycles, longer cycles. And so you need to wait out that first year and a half. And it's about a year and a half, 2 years. If they're still having problems with their cycles or pain, you need to start looking into it. And what I would tell young girls is that's when you should start charting your cycles. Really get into it at that point, and their mom should be encouraging them to learn about their cycles. But give it time. One of the mistakes I see is people too quickly, their daughters are having trouble maybe within a few months of starting to have their periods, and they quickly get on the birth control pill instead of, okay, well, this could be normal. We need to wait it out. Let's figure out what's going on. And go from there. And I think people are so quick to put women or young girls, particularly, on hormonal contraceptives.
I think it's a quick fix. And I think a lot of people don't know about charting with cervical
Hmm.
mucus. But then it's also like, well, I just take them to the doctor and they give me this magic pill and then
Yeah.
my daughter feels
Yeah.
better. So you're asking
Yeah.
me to make sure my daughter observes her mucus and we put down when she's
Right.
on her period. And that just seems like so overwhelming. And then
Right.
but I think that, yeah, so I don't actually have children that have started their periods yet. So my
Yeah.
son's my oldest. And so, but it should be anytime in the
Yeah.
next couple of years. I
Yeah.
have a couple girls that one's
Yeah.
13 and the other's 10. And I plan on, like we have an
Yeah.
ongoing conversation about our body and the way it works. And I was really irregular too. And my periods were so bad. And so my mom took me to a doctor and right away I went home with a prescription for the pill.
Mhm. Yeah, absolutely. I think it's so important that these young girls learn about their cycles, learn about what their body's supposed to do. Because I think one thing that's really important is I even teach teenagers is the reason why we have menstrual cycles, the reason why we have these cycles, that is because the reproductive system is designed to become pregnant. This is its purpose. And so if we understand its purpose, then we can utilize it how we should, which means, of course, I do not encourage teenage girls to go out and become pregnant, but I think it's important for them to understand why their body is doing this. Because
Yes.
we think of our periods as being this horrible thing. Why is our body doing this? Well, if you understand that each cycle the body is trying to become pregnant with the reproductive system, that's its ultimate goal, then you can understand, okay, the body is recognizing it didn't achieve that goal, so it's starting again. Now, this is the beautiful thing about teaching. Once you understand how your cycles work, then you teach young teenagers, young adults, okay, you can teach them about chastity, self-respect. This is how your body works. And then when you are ready and you meet the right man and you marry that man,
Yes.
then you can use it to achieve or avoid pregnancy. And you've already set the stage for success later. I take care of lots of, teenagers, young college students, and it's so gratifying. I'm old enough now that some of them are starting to get married and have babies, when I took care of them in high school and college. But it's so gratifying when maybe they did have problems and we got on top of it before
Yes.
they got married. And they also know that when they get married or they're engaged, they're already thinking, hey, I might have problems getting pregnant and I
Yes.
want to be proactive. I want to be on top of it. And I feel like it seems from that group of women to have less heartache. They're doing it
Yes.
the right way and they're on top of it, and they can be more proactive instead of, well, I had horrible periods or I was really irregular or I had pain. I went on the birth control pill. I got married. I stayed on the birth control pill
I know.
for 5 years. Then I decided I want to get pregnant. And 5 years later, I'm still trying to get pregnant. And we hear this story all the time. And I think
Yeah.
it's much better if we're in the first group where we're proactive.
Yeah, and I think there's also something to knowing, especially if you have a family history like myself, for my
Hmm.
girls, like talking to them about the gift. Like we're very pro theology
Yeah.
of the body, and
Yes.
the
Yes.
gift and beauty of our sexuality. And my 10-year-old has already said she wants to get married when she's 18 and wants to have
Uh-huh.
multiple sets of twins, and like she's got this plan, right? And I'm like,
Yes.
I love that. I don't know that that's the Lord's will, but we will see.
Right.
But I love like her enthusiasm for that. And it's like, that's what I want to
Right.
do. And
Right.
so, and I'm very grateful that I learned how to chart prior to Matt and I getting engaged. Even before I even met my husband, I was charting because I had a surgery, a laparoscopy for endometriosis prior. And then right
Hmm.
after we got married, we're like, we don't want to mess around. We want to have kids. And we had another
Right.
one. And so someone recently was writing to me about pregnancy in your 30s versus 20s. I was like, you know what? I only had one and
Hmm.
he almost died. And then I lost a few after that. And I'm like, I wasn't able to have, I had a child that was a preemie and had a hard time surviving. But for me, that wasn't in the cards. I have a friend who's 50 and she's pregnant, which is amazing and beautiful. But
Hmm.
she's been having kids for decades,
Hmm. Right. Right.
but that's not the norm. And that wasn't like if I waited till I was ready to have kids, I feel like I just now be having kids. And it's not
Right.
on the cards. Like pregnancy is not a right that we get. Like it
Hmm.
is a gift.
hmm And I think that concept of children as a gift is so foreign to
Yeah.
many in the world. And I think children are viewed as a right and something that we should all have access to. But in the end, it really, they are gifts. And if you read like, Humani Vitae, what is one of the things it says? Children are the supreme gift of marriage. Okay, so
Hmm.
not the supreme right, the supreme gift. And I think that's so important. And children, when you talk to parents and their children, it's so amazing when they're open to life, um, their idea of when they want to have more children or how many they might have. And you see an evolution in their thought process. I've
Yeah.
had women come to me and there's one, I just absolutely love her. And I'm thinking, she got pregnant with her first. And I remember she's like, well, we're going to wait several years in between pregnancies. Great. That's what she and her husband have decided was best for them. But shortly after she had her baby, I remember she came back. She was actually, we're gonna bring that in a little bit closer. We're not gonna wait that long because they just love being parents. They wanted another one,
Yes.
and what they thought before they gave birth was they wanted space in between. They changed their mind, and I think that's a beautiful thing. You're not fixed into a group of you have to have 2 kids or 3 kids or one or four. I think couples should be able to be given the information so they can determine, and I would say with God, the right size of the family for them. That you should be able to achieve or avoid, space them out as is appropriate for each family. And every family is unique and individual.
Yes. Yeah, it is. It's very, yeah, very unique. Per every marriage is so different, right? Even if you
Mm-hmm.
took those of us women with health issues, and compared, like it's still so unique within, or those that are just like my friend Kristalina Everett. We always joke every time Jason looks at her, she's pregnant. Um, and
Yeah,
Beth Shree tends to fall more in that. I have friends that fall in that category, but even the
yeah,
two of them, like looking at the Everett marriage and the Shree marriage, like it's very different. Like
right.
it's unique to who they are, and then even couples that struggle with stuff, like it's still unique to. Even if I was married to someone else, it would be different than me married to my husband, and
That's
having that
exactly right.
ongoing conversation. So, what do you
Yeah.
recommend for parents that are listening and are like, oh gosh, this isn't even on my radar, and I have an 11-year-old or a 12-year-old?
Mm-hmm.
What do you recommend? Do you recommend that they do Creighton NFP? Do you do a full on? Do you have a more child
Yeah.
friendly? What do you recommend?
Yeah. Well, I think that's a great question. So I deal mostly with the crate model in my practice. So of course, my natural inclination is to refer them to, a crate model practitioner where they can learn about their bodies. Of course, things get streamlined a little bit differently for them. We do teach them about pregnancy because it is important. These girls do need to understand what their bodies are doing, but it's more of an understanding than of what their bodies are meant to do and what that means. And we have had many teenagers chart their cycles, and my dad used to say teenagers were some of his best charters. So you hear a lot of the times from parents, oh, they're not going to want to do that or they can't do that. Well, they're selling their children short a little bit by just assuming they're not going to want to. The other thing too is when girls have health problems, guess what? They love to chart because they feel better when they get their problems fixed. And that's really, really important. And sometimes I think we are under the impression that unless it's a medicine they can just take every day, they're not going to want to do it. But I've had so many girls tell me, I feel so much better. Like, I love this. I wish my friends did this. I wish more people knew about it. And these are not necessarily women in their 30s. These are high school students, college age girls. So I think really, and the other thing too is, you can check with your local diocese. Some dioceses have programs designed for the young adolescent entering puberty for boys and girls. I believe like the St. Louis, in St. Louis, they have programs. When I was a resident down in St. Louis, I remember they were hosting programs. I don't know if they still do. But there might be local resources like that. But definitely those girls deserve the opportunity to understand what their body is doing. Puberty is a scary time for many different reasons for a lot of people. The last thing you need to do is make their bodies a scarier proposition.
No.
Give them the tools and the information so that they can go forward and understand what's going on and not be afraid of their bodies.
Yeah. Yeah, and it be more normal. And then it, just like you were saying, within a marriage, when you're discerning when it's best, like I feel like so often it was the ongoing conversation that had us be ready for another child sooner, was because it was
Yeah,
like, okay, well, last month you were saying you weren't in a good place because the baby wasn't sleeping through the night or whatever it was, you know, and it's like, okay, how are you now? And I feel like having that ongoing conversation with your child when it's like, okay, well, you know, you were afraid before you got your period, but now you see there's really nothing to be afraid of, and this is what we're doing. And now there's so many great products out there. Like I just ordered, they have like underwear that's like organic underwear, and it like
right,
has an absorption layer. So like if you get your period and you're not home, like you're
right.
okay, and it like makes it less scary, or like reusable organic pads that you can just wash
Hmm.
or whatever.
Hmm.
Or when I was a kid, I feel like all the pads and all the tampons, I think all of them were scented, or at least the ones we bought were all scented. And it's like, who knows what type of chemicals those are, you
Yeah,
know? And
yeah.
like
Oh,
I was an
and they're not.
irresponsible teenager.
Yeah, and they
So
don't
like,
smell good either. I'll
no.
tell you that. They smell horrible.
Right?
So,
And it smells so bad. And so, yeah, there's so
yeah,
much better natural options now, I think, than there was 20 years ago.
yeah. Absolutely. And I think you're right. Just I think one thing about charting cycles in marriage is it forces a couple to communicate. Where are you
Yes.
really at? Where are we really at? Are you doing okay? No, I'm actually not. This is why I'm struggling and I'm afraid or I'm worried or I'm concerned or you know what? Actually, I would love to have another child right now. And I think it's every month, every cycle, you're
Hmm.
forced to talk. And
Yeah.
otherwise you can go a long, long time. And it really, I think, is a status check on the marriage. Where are we at? Where are we at as a couple, as a
Yes.
family? Can we do this? Should we not? Is this not a good time for us? And there are reasons to avoid. You don't have to be pregnant. The Catholic Church doesn't say you have to be pregnant every single time that you have the opportunity. Like, if you have serious reasons to avoid, you should. You know, and I
Yeah.
think that's important too.
And I think it's also treating us as adults. It's like you're an adult. You can make this
Right.
decision. Like it's not, because I think people often think, oh, well, you're Catholic, therefore you're anti-contraception, anti-IVF.
Right.
So you have no compassion on women. You want them to be pregnant 24/7 and do nothing
Yeah.
but give birth. And it's like,
Right.
wait, I'm sorry, who told you that? That's not
I
true.
know.
And,
It's
and
it, it, it's so frustrating when they say that. Go ahead, go ahead.
no, no, no. I think it is. And then it's like, actually, no, we're looking at the whole person. Like,
Hmm.
if anything, I think that argument can be had for your average gyno's office. Like, at
Yeah,
least my experience when I was younger, it's like, okay, so you're having painful periods, you're in this box. You probably, and honestly, I was told, well, you probably just have a leak, low pain tolerance. I'm like, I've dislocated bones and popped them back in and continued my sports game. You can't tell me I have a low pain tolerance. Like,
right.
this is not it.
No, it's totally correct. I mean, you get wrong information all the time, and I think it's a lack of understanding what menstrual cycles should be, how painful they should be, all of that. But you're absolutely right. you know, Couples deserve the right to determine how many children they want or deem appropriate for their family. We're not just advocating that everyone have 20 kids and that you're pregnant and breastfeeding all the time. And one thing that I love about I being in private practice and now having my own patients, it's totally different than when you're a resident because you're in and out of people's rooms. You have no idea who they are. But I really do love the opportunity to talk to parents and how big do you guys want to have your family? What are you guys thinking? And I love the open-ended question because I think people are shocked to know that there are actually people who do want 10 and 11 and 12 children. That's their dream family. And you know what? When you see a family that large, most people think every child after number 2 was an accident and not chosen, and I think it's such a misconception in our culture that if you have more than 3, they're all accidents. Like they never were supposed to be there. But people choose. And, when we talk about the right to choose and freedom, this is freedom.
Yes.
Determining the
Amen.
size of your family, that is actual freedom. And you can't do that unless you understand your body. So, it goes back to the very core of everything. You have to understand your body, and that's where charting is so important. It will lead to that freedom. And it's beautiful. I love seeing it in families all the time.
Yeah, yeah, I love that. And then I also think, excuse me, we have a lot of people that are really big into clean eating and only buying organic and making sure like everything, like all household products, there's no chemicals. But a lot of these same people are on the pill or have an IUD or have an implant to prevent pregnancy. Could you talk to that a little bit?
Yeah. Well, I think it's a great point and even a comment to elaborate on, because there are so many people who our health status as a society, I think we're much more health conscious in many ways, but hormonal contraceptives is just so pervasive throughout our culture that it's just expected everybody be on it. And very few people actually look at what are the side effects, what is it doing to my body, all of those things. And I take care of a lot of women who've been on contraceptives before, and I hear many times, I never want to be on that. I hated how I felt. It changed my mood. I gained weight. I was bleeding all the time. It didn't fix anything. Um, and a lot of times women are happy to give it up, which is not what you would be. I think society would tell us that's not what you would expect. There are risks to being on hormonal contraceptives too. Higher risk of blood clots. There's some studies that talk about higher risk for breast cancer. So there's many things out there that increase our risk, and it's not congruent to be conscious about your health and everything else, but not with your reproductive health. That should go hand in hand. If you're worried about your heart health, your lung health, your gut, the reproductive system, those hormones, they're just as important. They play a different role, but still important. And I think it's just it's a commentary, I think, just on our society and what we've accepted as just the norm more than anything else. I think people honestly don't think twice about it, and and that's just because it's so pervasive. Everyone's on it, the birth control pill or has IUD. Um, so many people just don't think twice.
Yeah, my in my experience, the most powerful conversations I've had with friends are when they try to get off of it and then they try to get pregnant, and it's miscarriage after miscarriage.
Mhm.
And so loving them in that and knowing the loss of having a miscarriage and like, I'm so sorry, that's so rough, and like,
Mhm.
I don't know what's wrong with me, and I'm like, I think maybe it's what your body's been having. And then telling
Right.
them about napro technology, and they're kind of blown away, and they're like, I've never heard of this, like, why is this
Mhm.
not. And I think that the joke that I've heard is like, you're interested in napro technology if you're a hippie and you're really into natural things, or if
Yes.
you're a faithful person trying to follow, biblical teachings. And so it's
Right.
kind of like, okay, we're for Christians and we're for hippie people. And people are like, Cameron,
Right.
you're both and. I'm like, yeah, I kind of am both and. That's fair.
It's true. I mean, really, my dad would say that Catholic women are some of the most underserved, population, just because when it comes to healthcare, in that there are very few options that are respectful of our faith, right? And so, I think it is important to understand that when we talk about following our faith and not being on hormonal contraceptives, not using birth control for contraceptive purposes, what we also are not doing is we're not sacrificing good care. So I
Yes.
think so many people think if you're not birth control, your doctor is not taking good care of you. That is absolutely the opposite. What we want is a healthcare system that is supportive of our faith and our beliefs, but is excellent healthcare. So when we're working in NAPRO, we like are striving for excellence, and there are things we still don't understand, and we're working hard to figure them out, but we are not satisfied with subpar care. And so it's not an either or. It's not that you can follow your faith or have good care. It should be
No.
both.
Both
And
and.
it should be both. And we have lots of couples who come to us who actually aren't Catholic, and the reason they come to us is because they have failed their IVF, or their intrauterine insemination or everything else has not worked, and they are looking for an answer, and they finally hear about us, and they come, to us as a last resort, and they're so grateful when they
Now
hear what we can
explain that
offer.
to our listeners, because
Yes.
talk about IVF and then why so many, because I know a lot of couples that have failed IVF multiple rounds, yet they come to you, and through NAPRO technology, they're able to have children. Explain why that is.
Sure. So just for those who may not know, IVF is in vitro fertilization, and that's where the egg and the sperm are combined outside of the couple. So typically, in a laboratory, you have a medical doctor or a PhD level putting your egg and sperm together, and then they reintroduce the embryo into the woman later on. So IVF actually is not as successful as many would like to think. And one of the reasons why is it kind of bypasses the underlying causes. Many of the issues that lead to infertility also lead to miscarriage, for example. So you're looking at endometriosis, poor hormones, chronic endometritis or chronic inflammation of the lining of the uterus. Those are just a handful, and there's many more. And so if you don't correct the underlying condition, you still have this roadblock against the baby that you're putting in the uterus. So you are basically in some ways asking for failure
Yeah.
because you haven't corrected the supportive environment that that baby needs to thrive and to grow. And so you're not going to be as successful as you want. And so that's one of the problems with IVF.
Yeah. And then, so you basically kind of fix the problem of why IVF wasn't going to be successful anyhow, and you make the
Mm-hmm.
woman much more healthy, and then they're able to use more natural means, just coming together as man and woman,
Yeah.
to then get pregnant, and then you find that they're more likely to be able to keep that pregnancy. Is that correct?
That's correct. So for us, we're all about really finding the underlying causes of why they can't get pregnant or why they're having recurrent miscarriage so that we can support the reproductive system, we can support the woman's health, and then that's going to optimize everything to give them the best opportunity to become pregnant. We always tell patients we can't guarantee you're going to become pregnant
No.
um, for a couple of reasons. One, there's still many unknowns in fertility. It's actually, in some ways, a very simple process, but so complex.
Yeah.
Um, and it's really a beautiful system, but there's so much we have yet to learn. So no program has 100% pregnancy rates. The second thing is children are a gift too. We don't get to deem who
Yeah.
has a child or not. But it's really fascinating because many patients, once we can get them past all these issues, there's a group of women that we don't have to help them again with pregnancy number 2, 3, or 4, and they're just like, hey, I'm pregnant again, that was really easy. And likewise, there's a group of women who have to come and they need our help to support their cycles with every pregnancy. And so what we do is we're trying to help the woman by correcting the underlying issues. She's going to feel better, and that's what I hear many times. Dr. Hilgers, I had one patient. She was like, Dr. Hilgers, even if I never get pregnant, this was worth it because I feel so much better. And
Yeah.
so you're bringing back like that quality of life to them. You're probably supporting the marriage too in that process. I tell them all the time, don't forget about your marriage. Your marriage still is number one. You don't have kids right now. You got to keep that marriage strong. And then, you support them. And if there's a point where they don't become pregnant, they're either going to be more open to adoption or they're more understanding of why they didn't become pregnant and they can accept that. You know,
Yeah.
they accept, what, I could never get past the fact ovulation was my problem, or is endometriosis or something. But at least they have answers and it's easier for them to accept.
Yeah. And then what about when it's not the woman's health? Say you have a very
Yeah.
healthy woman and it's the man. It's the
Yeah.
husband who is struggling with fertility. Are you able to help him, or are you able to point them to someone who can?
Yeah. I think it's a great question. So obviously, sometimes it is the guy, the man. Sometimes it's both. But for male infertility, I think one of the problems with in vitro fertilization is it slowed our progress in determining causes and treatments of infertility. And the men have suffered because of this, because many doctors will say you have low sperm count or this or that. Your only option is in vitro fertilization. So the struggle is finding, really the biggest struggle we have is just finding, a physician in their area. We have many patients who come to us and then they go back home. So they may not be close to us long term, but finding somebody who can help the husband. There are certain medications you can use, but there could be different things impacting their fertility. And actually, we need a lot of work in both female and male infertility that needs to be done.
Yeah, which leads me to your next, one of the things that you do there is you train other doctors and practitioners from around
Yes.
the country or world, actually, I think.
World.
Tell us
Yeah,
more.
around the
Yeah,
world.
tell us more about that.
Yeah, so like I said, education is really important for us, not just of our patients, but in order to have these women and couples understand their bodies, they have to have what we call a crate model practitioner, and those are typically women. There are a few men who are practitioners, but they go through a pretty rigorous 13-month training program. Where they have a supervisor and they're taught how to teach these couples. And we have practitioners all over the world. We hold this course in Omaha. There's one course a year, but there are smaller programs throughout the country and the world too. And then at the Omaha program, we have doctors that we train as well. So we just finished the program in April, and we had 14 different countries represented. So we had we had like 3 from Brazil, 6 from France, 6 from Spain, Portugal, Hungary, trying to think where else, just all over, South Korea.
Praise God. Yeah.
And so just really spreading the word. And then, so they learn how to do what we call medical naprotechnology, those medical consultants. And then we have a 1-year postgraduate fellowship. So those physicians in the United States who've graduated from medical school and then completed a residency program, which is where you specialize. So, for example, in obstetrics and gynecology, it's 4 additional years after medical school. We train 2 to 3 of those physicians every year in learning how to do what we call surgical naprotechnology and more advanced medical naprotechnology. We deal a lot with surgical physical abnormalities that require surgical treatment, particularly endometriosis, for example. And we have to do it in a way where we don't create scar tissue. Scar tissue is where things stick together that shouldn't. So many of our reproductive organs, our ovaries, our fallopian tubes, our uterus, they're actually mobile organs. They have fixed points. They're supposed to be mobile. And if you get scar tissue, just imagine when you if you're walking and step on gum on the street and all of a sudden you're stuck, that's what scar tissue is like, except it's not easily broken up. And one of the problems with surgery is scar tissue is a risk factor, but we've developed here at the St. Paul Six Institute in Omaha how to minimize the risk of adhesion formation. So we have very complex cases come to us, and we train these young doctors how to do that. We just graduated 2 of them yesterday. They have 1.5 more weeks with us before they leave and move on to their jobs. But and then we have 2 more starting August 1st. So we have to train more doctors, and we just have to get these people out there, these young professionals.
Yeah, I wish that I had more. When I had my 3rd C-section, it was my first American one. I tried for VBACs every time, but it was a doctor in San Diego who was the only one he was very natural, and he was the only one willing to take me to try for a VBAC after 2 foreign cesareans. And in Ireland, it was pelvic bone to pelvic bone. So it was a very large C-section. But unfortunately, I had to have another one. But he was beautiful and lowered the curtain. I got to see my daughter come out. It was my best birth by far. And she was on my cheek as I was still being sewn up. But he said, he's like, I have to cut out your scar. There is so much scar tissue. So we did like a big football around it. But he just said, he's like, all your stuff's super glued together. Like like there's like webs in here. He's like, I've never seen this. Hindsight, I think it's I think people that have EDS, Ehlers-Danlos syndrome, struggle with like a lot of scar tissue as well. And then I've had multiple laparoscopies, and when I ended up having to have a hysterectomy, the doctor said the same thing. He's like, he had to go in, but he said a laparoscopy, or a lapar, what do they call that procedure when they go in like through robotics?
Yeah, like a robotic assisted surgery. It's
Yeah,
minimally invasive.
yeah, it's minimally. So he did something that was minimally invasive, but it wasn't robotics. And he said because he had too many things he had to work around. He's like, had I
Yeah,
gone in the way you were supposed to go in, it would have gone through your bladder, your
yeah,
uterus, some of your bowels, or some
yeah.
of your intestines, and like it was multiple things. He's like, it's just all, yeah. The way he put it was like spider webs, kind of all
Oh,
over.
yeah. I can imagine. I've seen pelvises
Have
just
you?
like that, and oh yeah, and surgery causes it. Yes, Ehlers-Danlos patients are known to scar a little bit more. Endometriosis causes scarring.
Well,
It's
there you
so
go.
inflammatory. So
Yeah.
you'll have women come to us who've never had surgery and they've got adhesions, scar tissue all over because of
Really? Even though they've
inflammation.
never had, wow,
That's
that's
exactly right.
interesting.
Yeah, the endometriosis alone will cause significant scarring, which causes pain, and then it can cause fertility issues too, if the fallopian tubes and the ovaries are negatively impacted because of the scarring.
Right.
Yeah, so we deal with a lot of that pretty frequently.
Yeah.
Hmm.
Hindsight, I wish I'd come to y'all before, but it was one of those that I was just so sick and the idea of
Yeah,
traveling. And now I'm still so sick. And I'm like, maybe
yeah.
if I had just fast forward and gone but,
Oh, but you do the best with, the one thing is you do the best with what you know at the time, right?
yes,
And
yes,
you
this is
can't
true.
always kick yourself. If as long as you made the best decision as you could with what you knew,
Yeah. Yeah,
that's
I
what
have
you
a
go with.
friend who is right around, or I think she's just older than me. I want to say she's maybe 43, but she's struggled with endometriosis and infertility. And she's like, she's like, they've tried to get pregnant over and over. And she's like, I think I just need to go ahead and get a hysterectomy. My doctor's saying there's no other option. And I told her, I'm like, fly to Omaha. Like, just do
Yeah,
it. Like, don't, even if you have to, just go there and then you know. And even if it's not to have another child, like maybe the Lord doesn't will that they've adopted, but I'm like, even if not just for another child, but just to know that you've done everything you can to get your body as healthy as possible. Have you had women similar to that have been suffering for many,
absolutely.
many years and then you're their last resort? Tell me what happens to them.
Yeah, I mean, so not everyone who comes to us is fertility. We have women who come to us just with significant pain or abnormal bleeding, and they're like, "Look, I don't want a hysterectomy right now. I want to figure out what's going on." And many times they're actually okay with the hysterectomy if that's what you really need. But we're of the mindset we want to just fix the problem, and if that, a lot of times that's going to fix your symptoms. Maybe you don't need a hysterectomy, and I've had women come to me post hysterectomy still with a lot of pain, and the reason why is so they don't have their uterus anymore, their fallopian tubes, in some cases their ovaries, but the endometriosis wasn't all removed, or they had scar tissue, and so you have to get all of the endometriosis out in order to get the pain relief you really desire. And so, if that doesn't happen, then the hysterectomy, unfortunately, probably didn't really help them as much as it was they thought it would, because there's still disease left behind, and so it's really important that you get it all. And so, yeah, we have lots of women who come to us just because of their pain, their bleeding, and they're
Yeah.
not trying to get pregnant.
If someone knows that they've been checked out and they're fine, but their husband is the reason, do you still
Mhm.
recommend them coming here? You said that there obviously needs to be more, but there is some things you can do
Right.
at your practice there.
Right. Well, I think one of the most important things is that they create, well, for us, we would say chart with the Creighton model, because we have seen couples with low sperm counts, low motility, and using days of fertility alone is going to improve your chances of becoming pregnant. And then, of course, we recommend that they have, a proper evaluation for their husband. For us, many times the conversation comes down, well, let's just really make sure the woman is fine, that there isn't anything we have to address on her end. A lot of times there are things, and so you want to optimize her health just as much, because if the man is really struggling, if you have two who are really struggling, it's going to be a lot harder. So you make sure that she's okay. And one thing about the Crate Model chart that I love is there are certain things called biomarkers on there. So when I look at a chart, I'm looking for normal and abnormal. So I know what my normal parameters are, and I know what's abnormal. And sometimes, for example, brown bleeding at the end of the period can tell me something. Limited mucus tells me something. So there's certain things that I'm like, maybe your cycles aren't as healthy as you think, too. Or you really you get a good history and really talk to them and say, okay, do we really need to do more for the women or not?
Yeah, I have a friend who didn't think she had any issues, and then someone did a laparoscopy just to like double check, and she did. She had horrible endometriosis.
Yeah,
She had a ectopic pregnancy, lost that
yeah,
tube, and then it was way easier for her to conceive when she only had one
yeah,
functioning tube, which
yeah.
is just so not the way you expect things to be. But it's like, let's make you as optimum. And yeah, and I
That's
think there is something to really taking advantage of those fertile days and knowing when they are.
absolutely. And yeah, the interesting thing is sometimes for some women, their history of miscarriage or infertility is their only symptom of endometriosis. So we have a study of like 660 couples, and of those 660, the woman, was 77.48% of the time had endometriosis. And I'm
Wow.
amazed at endometriosis. The amount that you have does not follow the symptoms. So you can have some women with significant pain who just have a little bit, and you can have some
Wow.
women with significant pain that's everywhere. And likewise, I have seen women with very little pain or no pain. They have other issues. I put a camera in there, and endometriosis is everywhere. You're talking, on their bowels, on their upper abdomen,
Yeah.
and so it's a disease that doesn't follow the symptoms in a lot of ways. So it's a
Interesting.
crazy disease.
Yeah, yeah,
Hmm.
it really is. And I think that I think the I think our society has made it so much worse because I think people just suffer in silence and don't know there's any other option. So
Right,
that's my hope in
right,
having you on too, that other
yeah,
people are like, wait, there can be answers. It's not just this
yeah,
one. If this one thing doesn't help
yeah,
you, there's no other. I want to take questions from our patrons.
sure, sure.
And then people that are watching live, I know we have a lot of people live on YouTube right now. Put your questions in on here, and just put it in the live comment feed, and I'll get to you after I get to our patrons. Okay, so I have a question. How do you best support and help couples who are on the high end of fertility spectrum, who are okay and with being open to life, but who aren't called to break any records, especially when a method failure pregnancy occurs?
Yeah. Well, that's a great question. So you hear a lot of times couples will say, "Oh, we're super fertile," and I used to think, yeah, some women are just more fertile than others. Well, I got corrected one day, and it's actually just normal fertility. And
Okay.
so it's actually just normal. 76% of women, well, will become pregnant. The first cycle, they use days of fertility. So if that's 3 out of 4
Really?
women, it's
Is that
very
that
high.
high?
If you have normal fertility and you know when you're fertile, it's actually very high. So then you can say, yeah, actually, I have a pretty good shot of becoming pregnant the first time we try with days of fertility. But likewise, sometimes for some couples, that means they're having children really close together too. And that might be hard for them. And definitely, spacing children doesn't always mean that you're not open to life. So for those couples who might need a little bit more space in between their children, there's different things that you can do. So I think number one, you need to be charting your cycles and need to be up to date with your teacher. The second thing is in the Crate Model system, we recently published a paper in the last 2 to 3 years probably, where if you do a progesterone draw on what we call peak plus 3, so that's 3 days after the a sign associated with ovulation, and if that level is above a certain number, then you use days for intercourse after that. It's called a family planning progesterone level. And there were no pregnancies when we did that, because the whole concept is you're post ovulation. And so if you choose those days, you'll have 100% success, be successful in avoiding a pregnancy. There was nobody who became pregnant, and we studied this, we researched this. There were like over 600 cycles in this study. Um, and then likewise for those couples who are charting their cycles and are doing well, but maybe they were using it to avoid, but they became pregnant. We typically recommend, actually, I should say we always recommend that they meet with their teacher, and we have something in the Creighton model system called a pregnancy evaluation. And that's where they really go through the chart, they talk about what was going on, and try to determine maybe what happened in that cycle so that you have more information going forward. There are many things that could potentially lead to that. And so I think all of those pieces of information can be really important for a couple who wants a space, maybe had a pregnancy that appeared to be method related, just to give them more information for going forward.
Um, yeah, no, that's really good and helpful. And then, what is, oh, I had a follow-up question. I forget what it was.
That's okay. I forget things all
Oh,
the time.
yeah. Yeah, no, no, no. I remember Calcutta. Someone told
Yeah.
me that one of the best studies on NFP or like showed how widely it's used or whatever is in Calcutta. Do you know about this study? Do you know what I'm
Oh,
talking
no,
about?
I don't. I actually don't know what this is. No,
Okay,
I
well,
should look it up.
yeah, someone told me they like quoted sometime that, the gist of it was that using NFP was more productive and worked better than using contraception. And they
Hmm.
did a study of people in Calcutta, of all places, because so many people,
Right.
and I'll give you a hint, there was a little short nun who taught everyone.
Yes. Yes.
So it was Mother Teresa that taught them how to use Creighton, and they were able to figure out so many because they're just really poor, right? So many of them weren't able to see doctors, and then through her and her order teaching NFP, I don't know what type of NFP, but some type of NFP, they were able to help just get the women so much healthier.
Yeah.
And they
Yeah.
used different things, and anyhow, it was fascinating. It was so long ago that I heard that, but I just thought it was great. I
Well,
was like, wow.
it's actually true. If you're looking at the effectiveness, so for Creighton, for example, the effectiveness in avoiding pregnancy is 96.8%. Likewise, for birth control pills, they will say it's 91%. They'll use the terms preventing pregnancy. So we're different. We're not contraceptive. You either choose to avoid or achieve if you're generally active. But in that regard, it's much more effective. And just real quick on the Calcutta, I think another misconception, I think there's a couple misconceptions with natural family planning, charting your cycles, is that you have to be educated and you can't be poor. Because people, it's really kind of sad. When I was interviewing for residency, they knew my beliefs. I had to bring it up, like, I'm not going to prescribe contraceptives. How will that work in your residency program? Because I'm not the normal applicant they would get. And one of them, I remember somebody who interviewed me brought up those who might be illiterate. How could they use the system? They just really thought you couldn't. And I was just thinking, I'm like, oh God, what do I say? But ultimately, I don't think patients are illiterate, especially when it comes to their body. Like, you
Yeah.
have a period, they can learn. And we use a picture dictionary to teach couples, so we
Yeah.
have visual references. And I think those are just excuses for not having people chart. And we have people of all Creighton model, for example, and I use this time and time again because that's what we use primarily here, but it's taught all over the world in all sorts of communities to all sorts of people, of different literacy backgrounds, different languages, all those things. So I think those are just excuses for not. And I think Calcutta is a great example. Many people would
Yeah.
probably just want to sterilize all of them.
I know, which would be so sad. I know that that's part of the problem in Africa. I've heard people speak out and say, you don't understand, you Americans. In Africa, our fertility is huge. That's
Yeah,
core of who we are as women. So you
yeah.
taking this from us is not freeing us.
Well, and we actually have a large group of providers, physicians, and crate model teachers in Nigeria, for example, and
Do
we have somebody
you?
in Egypt. Yeah, so Africa, we're there too. And no, I think it's really important. Different cultures and countries look at their fertility very differently, and we can't put our understanding onto other people. We just
Yeah.
have to be
And
able
I
to
think
teach them
it's,
and love them.
yes. And I think especially people that don't have access to all the healthcare that we do here in
Hmm.
North America. But a friend of mine who's trained in, she's a practitioner. She just in her city where she was with this one, I don't know how many women she's diagnosed, but cervical cancer. This one
Hmm.
doctor, the third woman, she said, you need to get tested. And the doctor, and what happened was he did a first test, it came back negative. And the next time she
Really?
met with her, have him follow up and that it was positive. It happened to two ladies. The third one came in, and I don't even think my friend knew it was all the same doctor. And
Yeah.
this doctor was like, "Give me this woman's number." Calls her up and is like,
Yeah.
"Who are you and how are you
Yeah.
diagnosing my patients? Like this
Yeah.
is
Yeah.
ridiculous."
Well, it's crazy, and one thing I love about the chart and is for us, it is a day-to-day medical record. When a woman, you bring in somebody who's not charting, and you go, "When was your last period?" and they look at you and they think, and they're like, "Well, I should know this. It wasn't too long ago," but it's really hard for them to remember because we live busy lives.
Yeah.
And especially if you're a mother with children, or if you're a professional, maybe you're not married, don't have children, it's really hard to keep track. And so how do you know if your bleeding is normal or abnormal? You just know, well, I'm bleeding and I think I'm having it
Yeah.
at regular intervals. And I had one patient tell me, I thought my cycles were regular. I didn't know how irregular they were until I started charting. And for a physician, like, it is night and day difference treating somebody who's charting versus somebody who's not. And I feel like my hands get tied behind my back if they're not charting. It's
Yeah.
just
It's
such a
like that
great tool
extra
for
set
us.
of eyes into their
It is.
life.
It tells you so much. And like, sometimes I'll talk to a patient and go, "Well, was that a stressful cycle?" And they're shocked that I can like figure that out. I'm like, "Well, it's totally abnormal to everything else. It shows all the signs of stress." So it's really fascinating. The chart, I always tell people, the chart doesn't lie. We just may not know exactly what it means yet.
Yeah. And you able to
Yeah.
decoding it for us, I think is
Yes.
huge. Okay, so the next patron question. Hi, my wife and I are very excited for this episode. Sadly, last September, we had to rush to the emergency room for an emergency surgery. It turns out that our baby implanted in my wife's tube. We lost the baby and the tube. We found out early next pregnancy, if we find out early next pregnancy, God willing, that our next child has the same idea, implanting in her other tube, should we go to a local ER? What's the best treatment medically and morally? Should we ask for anything in particular? Thanks so much for your work. We have been so blessed by the work of Pope Paul VI Institute in NAPRO technology.
I think that's a great question. So tubal pregnancies or ectopic pregnancies, the problem with them is when the baby implants with the tube and grows, that tube is not like the uterus, where the uterus is a big muscle. It can grow and accommodate that baby. The tube can't. And so the fallopian tube, the risk to a tubal pregnancy is that it will rupture. So it's something that we worry about. And that's oftentimes why the fallopian tube gets removed. For us, the question is, why did the tubal pregnancy occur? And
Yeah.
so many times what we see in women with a history of miscarriage and tubal pregnancies is they have abnormal hormones, maybe abnormal ovulations, maybe they have some underlying tubal disease. And so we advocate get those corrected, because we find we haven't eliminated tubal pregnancy. So I don't want to give people the wrong idea that we've eliminated it. But we find that in our couples who we are treating for infertility, we have actually a very low tubal pregnancy rate, and that is likely, we think, because we're correcting all the underlying causes. We're getting their hormones corrected and all that. And likewise, for patients who are at higher risk for tubal pregnancy, we recommend you get an ultrasound early, 7 weeks,
Yeah.
so that we can see, is the baby in the uterus? Is there a heartbeat? Where is that baby at? Because if the baby's not in the uterus, then your doctor can work with you much more closely, monitor you, and then you probably have better, you know, time options and time frame for making the decisions you need to make in an ethical and medically appropriate manner, instead of running to the ER and needing to rush to surgery and all those things. So it gets a little bit more complex than that, but again, I would start charting. I would have make sure your hormones are figured out. And get an early ultrasound. Don't just rush to the ER. Get an early ultrasound. Know where that baby is.
And how can they find a NAPRO doctor? So like right now, if they're in between pregnancies, they're hoping for another, like now's really the time to go, right? And see you or one of your fellow doctors. Like, how do they find you?
That's a great question. So you can do that probably one of two ways. There's a website called, it's FCCA.org. So it's Fertility Care Centers of America. And you can type in your location and you can look for your teachers and you can look for medical doctors there who have been trained by us. The other thing you could do is you can email us at NAPRO questions. So that's NAPRO questions spelled out at St. Paul, SAINT, paulvi.com. And one of us can help guide you. If you tell us where you're at, we can say, yeah, we know somebody in this area, or we don't know somebody in your area, but we know somebody maybe near you. You might have to travel a bit too, but we can help you out.
Yeah. And I feel like traveling a bit to get answers is so worth the travel. It doesn't make sense. Like, even if I get a little sick and I have to see a doctor, I go to Cleveland or Columbus and people are like, we have doctors here. And I'm like, I've done that and I don't get any better. And they want to put me in the hospital and leave me there. And they don't know how to change course of treatment. And I'm like, I'm not doing that. Like, it seems foolish. Like, isn't the definition of insanity doing the same thing over and over?
Exactly. No, you're exactly right. And, traveling, the sad thing is that we have to travel. And, for us, we want to get good NAPRO physicians and medical consultants everywhere so that you don't have to travel. But we have a lot of patients who travel to us, and it's because they haven't found the answers nearby and they just want to get the care that they're seeking and desire.
Yeah. Okay. Next question. Can dehydration / liquid levels affect mucus?
I think so. I definitely encourage patients to hydrate. Other things can impact mucus, and probably what's more important is your stress levels. Stress can definitely decrease it. So monitoring your stress, hydration. You'll hear some patients say, I hydrate, it's a little bit better. Yeah. So definitely those things are all important. Hydration is good.
Am I correct in thinking that take your weight, cut it in half, and that's many ounces of water you should be having a day?
I actually have never thought of it that way. I tell people aim for at least 80 ounces, and then if you fall short, you're not too far off. If I tell you to aim for 60 or 40 and you fall short, you're probably too low. Yeah. And certain medicines can decrease your cervical mucus, like antihistamines. So, a lot of those allergy medicines you have to be a little bit careful with. So other things can impact cervical mucus too.
Yeah. And then other people that are overly mucousy, you have yellow stamps to help them sort through their...
Yeah, and for women who've had vaginal deliveries before, there's a condition called a cervical ectropion, which is kind of an inflammatory condition, and they're known to produce more mucus, and you can have that treated in the office, and that can decrease your mucus. You don't have to have had a history of a vaginal delivery to have it, but definitely women, if you charted before you became pregnant and then afterwards you're like, wow, where did all this mucus come from? You could very well have an ectropion. But your teacher can help you identify if maybe your chart looks like you have that. And we do exams in the office, look at the cervix and treat it. And a lot of times you can decrease that mucus. But yeah, yellow stamps, you can manage. You're not fertile every single day. Some women do have mucus every single day of their cycle. That doesn't mean they're fertile. You just need to know how to manage it. And so you have to work with the teacher to get it managed.
Yeah. And I think, I was a yellow stamper and we had to try for each of ours. So we had one surprise pregnancy and then the other 5, we were trying, Mm-hmm. And I know people use other forms of NFP and I'm not anti them, mm-hmm. but I know when it comes to achieving pregnancy, Creighton's always my go-to because I'm like, this is what actually, and if it wasn't for, and I've had friends that have charted with other methods and they couldn't get pregnant, and they switched to Creighton and they got
Hmm.
pregnant. And so
Right.
it's, I
Yeah.
just think
And
you're
I say,
very scientific.
yes, and the reason why we say Creighton, and like I mentioned, I do have patients who, for their NFP, they might use other methods, but when it comes to needing medical conditions treated, the reason why the Creighton model, there's advantages to it, and one is all the research was done with the Creighton model, so you'd almost have to rewrite that research with
Yeah.
every method and to figure out, well, how does this exactly correlate with that? And the Creighton model, due to its standardization, objective measures that we use, it tells us so much. And so that's why for anyone who needs medical treatment, we have them chart with Creighton model. If they're just coming to me for other reasons and they're happy with another method, I don't necessarily make them switch, just so you know that too.
Okay, that sounds good. Okay, and then what is some non-invasive ways to decrease inflammation in the pelvis?
Uh, that's $1 million question.
Right? I'm like, that's a really good
Yeah,
one. I think it was a husband that wrote that one in actually. So,
yeah, well, this is a tough question because we, in our fertility patients, our pain patients, what we see a lot of inflammation. You'll see it in the lining of the uterus, you'll see it in the pelvis. So the question is what's causing it? You don't always see it in women who have endometriosis, although if they have endometriosis, that for sure, um, uh, well, I shouldn't say for sure actually, but you'll see high associations with inflammation with endometriosis. So typically we say get the endometriosis out, but then how do you treat the inflammation? There's all sorts of things that people try to do, anti-inflammatory diets, supplements like turmeric, for example, is anti-inflammatory. For some, it works, but not for everybody. So this is why it's the $1 million question. What can we really do for the inflammation? I think in many ways, it probably starts with eating healthy, decreasing your stress levels, making sure your hormones are normal. Those are easy ways to go. You can do some anti-inflammatory supplements, but probably it comes down to what's actually causing the inflammation and what can you do about it.
yeah. I think that there's only so much. So I had a friend that was joking with me that she eats way worse than me. I'm like plant paradox. Like I'm like uber clean eating, and like right now I'm not doing any grains, I'm not doing any dairy, I'm not doing like so many things. And she's like, yet your body is way more toxic and messed up than mine. And I was like, yeah, that stinks. But
Yeah,
like you can't, like you've got to get rid of the underlying stuff, like the
yeah,
changing what you're, like it's good to start with diet. And I think a lot of people it
right,
does work,
right.
switching diet. But yeah.
Well, and they're just, yeah, there's just so much we don't understand still of inflammation, and I think a lot of it's the root cause, what's really causing it, and why does inflammation hit somebody harder than somebody else? And I
Yeah.
think that's important, because you can see two people with the same diet, and one is going to feel a lot worse on it than the other if you have everything else equal. It's interesting.
Yeah. Yeah.
Hmm.
It just goes back to we are so different, each as different human beings. Like, never mind, okay, males versus females. Like, we know that we're different. But it's like,
Right,
even take a whole group of females, divide us up by age, like everything. We're still so uniquely different.
right,
Um, which
exactly.
is, I feel like y'all are so good about seeing the individual person. And I think that um, through Creighton, you can see, you just have a better lens into the daily lives, and what the
Right.
body's trying to tell you. Okay, next question is, does progesterone sometimes lead to less mucus? Are there any negative effects with progesterone? Maybe if you can just talk about hormone therapy in general first and then
Yeah.
go into that.
Yeah, so progesterone is a hormone that I love. I use it all the time. But for those of you who may not really be familiar with it, so progesterone is produced after ovulation. So the follicle will grow to a point where then it ovulates and releases the egg. So the ovaries develop the cyst. After ovulation, that follicle transforms into the corpus luteum, which produces progesterone. And if you don't become pregnant, then the progesterone drops and you start a period. So we often see that women with premenstrual syndrome, infertility, miscarriages, they actually have low progesterone after ovulation. And so a few things with that is we'll supplement with progesterone. One of the natural things about progesterone is it changes the characteristics of the cervical mucus, so it's not as present. That's why typically after ovulation, most women with normal fertility are not going to have a cervical mucus discharge. So by its very nature, you're going to see a change. And so with progesterone, if you're using vaginal progesterone as a supplementation, you can take it orally, vaginally. You can take it as shots. But you can see a change in the cervical mucus and a decrease in that cervical mucus. But it shouldn't eliminate it.
Yeah. No, that's good. Thank you.
Mm-hmm.
Okay, our next question is okay, thank you so much for doing this. If you are not sexually active and never have been and are 31 years old, when, if ever, do you need to be going to an OBGYN before you are sexually active? My primary care doctor used to try to get me to have a pap smear, and I finally had one, and it was rather traumatic because the first time they didn't know how to use the right tools on a virgin and couldn't perform the tests, and everyone was very uncomfortable. Then I went and they performed the test, and everything came out fine. I have no family history. Oh, she has no family history, like not knowing because she's adopted. So what are your recommendations for her? And I think this is a lot of young women in their 20s, 30s, 40s.
Right. So if you're not sexually active, most cervical cancers are related to the human papillomavirus, which is typically a virus that's transmitted sexually. So for some women, they think, well, I've never had, I've never been sexually intimate before. I have no risk factors. Well, unfortunately, there are some cervical cancers that are not related to HPV or human papillomavirus. So that's why we still recommend, even if you're a virgin, to get your pap smears. Normally, the current recommendation is age 21, and if that's normal, it's every 3 years, and at 30, that changes. I think it can be very traumatic to young women, and it's important to find a physician you're comfortable with. I typically recommend that you do go to an OBGYN. Sometimes physicians and other specialties, they don't do it as often, the pap smear, and so if it's a little bit more difficult for them, the patient might pick up on that. Somebody who does pap smears frequently, so whether it's an OBGYN or family medicine, that's where I would go. But you should still get screened for cervical cancer because there are cervical cancers not at all related to being sexually active.
Yeah, I had a gynecologist on a previous episode, and she said that she's seen babies all the way through to 99-year-old women, right?
Yeah.
And she said that she can do a pap smear on all of them that are not
Mm-hmm.
painful. And so I
Right.
think I had a really horrible experience too. I think having a doctor that believes that you're a virgin, because I don't think mine believed me.
Yeah.
And mine was a PC. He should never, ever have been doing it. And I was a teenager. I was too young. There were so many things. But she said that she can do it in a way that's so non-invasive. And so I think finding someone that is overly qualified and does this all the time and someone that will believe you. So when you say, I'm a virgin, I've never had sex, I'm 31, they're like, yeah, sure, whatever, lady. I think that's huge.
Yeah, you have to find somebody who you'll be comfortable with during the exam. Everyone has different techniques. I had a friend one time, she told me, she goes, never go to a female OBGYN. All the pap smears are uncomfortable because they're women and they don't care. She's like, you got to go to a man because they don't get them. And this was her theory. And she was like, yeah, the guys are so much more gentle. So I always kind of chuckle at that. And in some ways, I think it matters more. It's the technique and, just are they going to make you feel comfortable? Because the moment a woman is not comfortable in that type of exam, it's all downhill from there. They tense
Yeah.
up and it doesn't help and it only makes things worse. So you got to be with somebody you feel comfortable, whether they're a male or a female.
I agree.
Either way, but you have to be comfortable with who's doing it.
Yeah, I've said that I would love to open up like a true women's health facility and in it, there's a waiting room where you can get a back massage or foot
Yeah,
spa,
yeah,
and then you go in and it's a beautiful room and there's real sheets, and
yeah,
it's not a
yeah.
sterile environment. It's clean, definitely
Right,
clean, and they
right,
do a good job cleaning it, but it's something that you're like, this is relaxing, and there's nice
right,
music playing, and it's very,
right.
very calming. Because I do think that the in and out sterile environment makes you that much more tense, and
Right.
yeah.
And I try to reassure all my patients. I don't know one woman who's like, yes, it's time for my pap smear. Thank goodness, it's my lucky day. Because I think sometimes women are self-conscious, like, I really don't want to be here. This is not what I'm looking forward to. And they feel like it's just them. And I just like to reassure people, honestly, no one likes it.
No.
It's truly a universal dislike. And but we'll get through it together,
Yeah.
and it can be done with it can be difficult for the physician. Different people are made differently. Depends where the cervix is. It depends on prior history, if they've had procedures on the cervix, things like that. But it can be done in a way that's not uncomfortable or scary for the patient.
Yeah. Okay, I think we already addressed this question, but we'll see if there's anything else we should add. This woman's heard that period pain and cramps is not actually normal. Is it true? And what can you do to get rid of the pain? I hate taking covering up problems pills with pain. I don't think it's a real solution. Any insight?
I think it's a great question. I think this is where we need to educate women, young teenagers, moms on what pain is supposed to be like. So, when I was in training, I thought everyone was supposed to have some type of pain where you're requiring
Yeah.
ibuprofen Tylenol. That just seemed to be kind of what we expected. But so now I treat a lot of women who have painful periods, endometriosis, and when I get rid of it, I'm amazed at how many of them say I have no pain or I have mild pain and maybe I need a little bit of ibuprofen. So what I've realized is if these are women who used to have significant pain, I really think our periods, the cramping and discomfort we should feel, should be minimal. None to maybe you need 200 or 400 milligrams of ibuprofen once or twice. You shouldn't need a lot of ibuprofen. A big warning sign to me is when you are taking lots of ibuprofen or leave some type of pain medicine. You can't skip a dose. If you're off at all, you're going to pay for it. Those are bad signs. Those are signs that
Yeah.
your pain is not normal. Most women can get through without pain medicines, and maybe they need a little bit, just to take the edge off. That's normal. Anything above and beyond that, I start to worry. Okay, why are they having that pain? It's also important too with your periods that you stay well hydrated. It's a big muscle, that uterus, so you don't want to dehydrate it. It's going to cause more cramping. Just like if you're dehydrating, you're running your legs, right? That's a muscle. It's going to cramp.
Yeah.
So, decreasing caffeine around the time of your period is important. Staying hydrated. But those measures don't always take away all the pain. And significant pain with your period is a problem. It's not normal.
Yeah. Yeah, I think that. And then do you find the sooner you can diagnose, the better? So, like, if it's a
Absolutely.
mom dealing with her teenage daughter, is it let her deal with this later when she gets married, or we should figure this out now?
Well, I think if I am all in favor of getting on top of it when you can. We take care of women of a wide range. Anyone a procreative age, for example. I've seen horrible endometriosis in 16-year-olds and 18-year-olds, like just horrible. And you think if you let that persist, it's just going to get worse and
Yeah.
progress. So I am a big believer, get on top of it, because then what you're doing later on is maintenance. You're proactive. You know what you're dealing with.
Yes.
Don't have these young girls suffer for years and years and years. And one of the problems with endometriosis is a delay in diagnosis. They say it takes
Yeah.
7 to 9 years before it gets diagnosed. One of the problems, though, is if you are going to take your daughter to somebody, they need to know what they're looking for, and they need to be able to perform the surgery in such a way that they don't create more problems like scar tissue.
Yeah.
So they have to know what they do. You can't just take them to any surgeon.
No, you want to find a NAPRO certified
Yeah,
surgeon.
yeah,
Okay.
absolutely,
Yeah.
yeah.
Great. Do you find most of the help is in Western medicine, or have you seen alternative methods helpful, like oils or foods or herbs?
That's a good question. For us, we obviously rely on a lot of Western medicine with our surgical techniques and our hormonal management. But I do have patients who rely on other things like acupuncture, for example. One of the things that we deal a lot with is what's the overall stress of the body, what's causing them issues, and I think acupuncture, for example, many of these women feel better afterwards. So, there are probably things that we could utilize that we just don't know about and do it better. But the thing is, whenever we start incorporating things, we have to, do our due diligence, make sure that it is effective, that it is working, it's not going to harm the patient. And there's a lot of things out there that could potentially be helpful.
Yeah, the American Orthodox doctor that I had wanted me to go to not just any chiropractor, this one that he knew that specialized in pregnant women, and then also an acupuncturist as I got close to the end. He's like, these are the things I need you to do because this is what helps. And then I think there was also a diet that he wanted me to follow. And it was like,
Yeah,
he's like, I tell people to feel free to do one of these like
yeah,
5 things. And he's like, for you, I want you to do them all. And it
yeah,
was the best I felt in pregnancy, you know?
yeah. Yeah, no,
Um,
I think there's some benefits to some of these, absolutely.
yeah. Okay, great. Thanks. Do you know much about pelvic floor therapy? What is it exactly, and what helps short term, long term? Would you suggest looking for a Catholic pelvic floor therapist, or does anyone count?
Great. So pelvic floor physical therapy is a great tool that I often utilize with my patients. I do think so. One thing just to know, the pelvis has a bunch of muscles that help with our stability and all these things. So one thing I worry about is residual pain following surgery. So when I remove endometriosis, I expect that the pain level should reduce 50 to 100%. And if they don't, I'm worried that there's something else contributing to the pain, like musculoskeletal. So the way I describe it to patients is when you're sick and you're in the fetal position, you're going to be in that way because it feels better. But if you were to stay in that position for a long time, you're probably going to get a low backache or an upper backache
Yeah.
because it's not normal. So women who are in chronic pain, it makes sense that they are probably training their muscles inappropriately to be protective. So then once you remove the pain stimulus, they have to retrain their muscles. So they might be tight or they might be standing, um, incorrectly. And so they have to get corrected. So pelvic floor physical therapy, one of the benefits to them over traditional physical therapy is just they have more of an emphasis on the pelvis and those muscles within the pelvic floor. For some women, they don't like it because it's a little bit more invasive. So you do need to know that they may do that. But for some women, pelvic floor physical therapy is really a great tool. It's maybe not needed for everybody. It depends on what your situation is. But I definitely do recommend it for patients. And I think in this case, what I would recommend a good pelvic floor physical therapist. They don't necessarily have to be Catholic. I think they have to be respectful of you as a human being and a woman.
Yes.
I think
Yes.
that's where, as long as they're respectful of you and are listening to you and are good, then that would be an acceptable physical
Yeah.
therapist.
And if they can work with your doctor. So I interviewed a physical therapist, a pelvic floor physical therapist. So you can look back at that episode, anyone, whoever's asking this question. But I had seen one physical therapist and I made a joke at my OB appointment, and I made a joke about Kegels or something. And she like
Yeah,
stopped mid checking me and was like, I'm so sorry. Did you say Kegels? And I was like,
yeah,
sorry. I get awkward in situations and I make jokes. She's like, no, 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 you're not doing that, are you? And I was like, yeah. She's like, what all is your physical therapist doing with you? And I told her,
yeah.
and she's like, stop now. Stop all the exercises. Stop everything you're doing. She's doing the wrong course of action.
Uh,
And so she's like, I sent her notes about you. And so it was good. Like, I think she was a good physical therapist, but she didn't
yeah,
read the notes that my doctor sent. And she's like, we're
yeah,
making things worse, not better. And so I switched to a
yeah.
different one. And she was very good about wanting to communicate with my doctor and saying, like, this
Hmm.
is the course of action I think you need. And um,
Right.
yeah, and so making sure that they can, and if there's something you're doing that doesn't work, like there was multiple things that I'd bring to her, and she's like, "Yeah, no, it shouldn't be like that. Let's change. Let's do this
Yep.
instead, or let's, yeah." So making sure someone can redo treatments with you by hearing your feedback. I think that's just a sign of
Right.
a good therapist or doctor is like when you give them feedback, they readjust according to that feedback because they're actually
So
listening to you.
yeah, listening is one of the best tools in medicine that we have. Like my dad would say, if you listen to your patients, most of the time they're going to tell you exactly what's going on, but you have to listen. And I think he's totally right. Patients tell us more. If we just listen, they tell us so much. But you have to pay attention and you have to want to listen. And it's one of the best pieces of advice he ever gave me.
Yeah, and I think that is also what we see the difference between people that view like you go to a lot of school, like it's a lot of work for you to become the
Yeah.
doctor that you are.
Yeah.
But I think that you would see it as like your vocation and also like a way of helping individuals. And not only do you not want to do any harm for your patients, but you really desire what is best for them. And in my experience, medical professionals that do that, like they're just such a better doctor.
Yeah, no, I mean, it is. It's a lot of training, it's a lot of work, but I think in the back of our minds, it truly is an honor for somebody to trust you with their health. If they become pregnant, with monitoring their pregnancy and delivering their babies. Like, I mean, what an amazing event to be invited
Yes.
essentially to be a part of. Yeah, I'm gonna have a baby, and you're gonna be the one who's gonna deliver my baby. Like it's a beautiful. Like I love delivering babies because, well, I just love the reactions on the parents. I love seeing the dads, especially new dads. They're just like, what's going on? The moms. I mean, it's just so beautiful. But it's truly an honorable profession, and I think sometimes we forget that it's an honor to be a part of it. And um, you know we don't have to be patients don't have to have us there. They could choose somebody else, but they choose you, and there's a reason. So we have to respect that.
Yeah, isn't that a gift? This will be our last question on here because you are talking about birth and delivery. One of our patrons is expecting their first baby, and she's wondering about postpartum tips and tricks. What foods to eat, avoid, best experiences, breastfeeding tips, vitamins, supplements, anything that you recommend. A new mom.
Yeah, yeah. So I think the first thing I recommend is you're going to have some tears and fatigue, and it's all okay. Um, what I would definitely recommend is just remember perspective. This is brand new to you. You don't know what it's like to be a mother. You don't know what breastfeeding is like. So take advantage of your resources. Lactation consultants, they're amazing. Get a good lactation consultant locally. Hopefully, in the hospital, they have somebody who you can work with, and then have recommendations once you leave the hospital to work with. Breastfeeding, can be difficult, and it can make or break, how great of a postpartum time frame you have or not. Um, so that's really important. I think too, in the hospital, I recommend to my patients set visiting hours. Even if the hospital doesn't have visiting hours, you should just let family or friends come at certain times of the day, because if you have a vaginal delivery, it's a lot of work, and you might be sore, you might be tired, you're up in the middle of the night with your baby, you need to rest and heal. If you had a C-section, that's a major surgery. So you shouldn't have people in your postpartum room for 12 hours a day. Like it's okay, set some rules. And then the other thing I just tell everybody is, just keep an eye out for postpartum blues and depression. And I think this is the thing, because many women don't recognize it. Sometimes I find it's a lot of times their husbands or maybe their moms or family members who are like, wow, something's not right. Because what happens is moms feel like, well, I don't know what I'm supposed to feel like. I think I'm supposed to feel this way. But, just some things to watch out for are, sleep is so important. So can you sleep when the baby's sleeping? Are you having excessive insomnia? Are you crying all the time? There will be tears of frustration, but are you crying all the time over spilt milk? That can be a problem. Hot flashes, night sweats, headaches, a feeling of hopelessness, strange thoughts, things that you wouldn't think are postpartum blues.
Yeah.
And it's often hormonal, and hormones are one of the best treatments for postpartum blues and depression. And
And I
so
think
those
not
are
being
just
a
the things.
yeah, and I think not being afraid to talk to a friend about it. So I remember
Yeah.
calling my friend Kana and telling her, I'm like, okay, I'm just really annoyed. Matt keeps saying he wants his wife back. And this was my fourth
Yeah.
child, right? And
Yeah.
I'm like, I just want him to leave me alone. I want everyone to leave me alone.
Yeah.
I'm not depressed. I just don't want to get out of bed or get dressed. And I don't want anyone to need anything from me. And she was so beautiful. And she was just like, all right, Cameron, that's fine. You're not depressed.
Yeah.
What I want you to do is call your doctor and tell
Yeah.
him that you need to get on antidepressant medication. Like you need
Yeah.
postpartum support right now. And for me, like it wasn't as soon as I had the baby. This was like I think 6 or 7 months after because he kept almost dying, which just made it really stressful. And I just didn't
Not good.
sleep.
Yeah.
And then what's interesting is I found I recovered so much more from my third C-section than my first two. And I was in rural Ireland. So my first C-section was an emergency C-section. They didn't give me any pain meds because I had GERD. So they were afraid that it
Yeah.
would hurt me. So my husband was sneaking in Panadol for me.
Oh
Like that
my
was it,
God.
just like normal
Yeah.
Tylenol. And then I shared a room with 10 other women and their
Yeah.
babies. And so that was
Yeah.
me trying to recover, right? So I think it's
Yeah.
funny that you're like, I was like, oh yeah, on my third baby, I had a room all to myself.
Yeah.
It was
It's
so much
amazing.
easier. Yeah. Yeah. And
Absolutely. Yeah, I
yeah,
was just gonna
sorry.
say for postpartum blues, actually, progesterone is a great treatment for postpartum blues depression too.
Is
Usually, I
it?
find
Okay.
yes, but I think just to speak to your point, you can have postpartum blues depression all the way up till when your menses return. So it can happen 6 months later or 4 months later.
Okay.
And a lot of times people think it happens right away, but it can be a delay.
Okay.
So I just think, honestly, I find the postpartum time frame, it's an exciting adventure. Don't be hard on yourself. You're supposed to rest and heal and just love on that baby. And, I would take all expectations off yourself, honestly. I think we have this perfect idea of what it is to have a delivery and recovery and the postpartum time, right? Throw it all out the window. Parenting, and maybe I'm wrong on this, but I feel like parenting is the biggest on the job training that you ever get. There's no
It
perfect
really
handbook
is.
for it.
You have no idea, even if you've been
Yeah.
around it before. Yeah.
Yeah.
Thank you so much. I really appreciate you taking this time out of your day and sharing with us. I would love to, if you wouldn't mind shooting me an email or having one of your ladies shoot
Sure.
me an email, someone that works for you. You mentioned where we can find a Creighton doctor where we can find a
Hmm.
NAPRO trained technician, someone to help us learn how to chart.
Right.
You also gave
Right.
an email address to write questions. So I see a lot of questions coming up in our thread right now.
Yeah,
And I would love to
absolutely.
get to all of them, but I think we already covered enough. But I love that you have that email address and anything else that you want me to point people listening to right now, where to point them, and I'll put it all in our show notes.
Okay. Well, thank you so much. It was so wonderful to be here again. It was just so much fun to talk to you and answer these questions and, hopefully help a few people out there.
Oh my goodness, you're going to help so many people. So thank you so much. And God
Okay.
bless you. And we will continue to pray for you and all of y'all at the Pope Paul VI Institute.
Oh, thank you so much. We need the prayers. Keep them coming. Absolutely. Thank you. And I really appreciate being here with you today, Cameron.
All right. Thanks so much.
Okay. Bye.